So let's talk about lumbar spinal stenosis in terms of when it does need surgery. Again, going over the definitions. Lumbar, here's the lumbar spine. You have cervical, thoracic, lumbars from the ribs down. L1, L2, L3, L4, L5. Between each of these between each of these bones is a disc. In the back part, we have all of the nerves. They run down this thecal sac. Your spinal cord stops kind of right at the bottom of your rib cage and then runs down all the way to your butt is a sac filled with all these nerves swimming down. When you get compression of those nerves in the lumbar spine, that's lumbar spinal stenosis, squeezing those nerves. That can cause numbness and tingling in different areas. The front of your thighs, side of your thighs, down your leg, into your toes. It can cause shooting pain into the butt, deep in the butt. That can be when the S1 or the L5 nerve is squeezed and pinched. Again, the reason people get spinal stenosis is either arthritis in the joints that create bone spurs, thickened tissue, that's a wear and tear arthritic condition where this tissue that protects all the nerves starts getting thick, just like you get a callus formation on your hand. You can get that same symptomatology down the lumbar spine of a thickened ligamentum flavum. You can have disc herniations that push out and squeeze everything. You can have instability where these joints get so arthritic, the bone slips forward and it just cuts down that tunnel. It'd be like if you have two bones on top of each other, if they start slipping, you can see how it would be squeezing those nerves back there. That's another way you get spinal stenosis. And then the other ways that I'm just going to skim over because it's a smaller subset, infection, so the pus from the infection, that's much more common in immunocompromised or IV drug users. So I hope none of you guys are IV drug users. Also in trauma, car accidents, fractures, motorcycle accidents where the bones fracture, and then tumor, most commonly metastatic tumor that spreads and grows from the bone into the spinal canal. So in terms of the surgical treatment, patients should have surgery for spinal stenosis when it's causing symptoms that are ruining your life. And ruining your life is a very vague term, right? That could be different for everybody. Here's kind of how I look at it. If this is something that keeps you from doing the things that you like, then you should have surgery for it if you failed non-surgical treatment. So I frequently see patients that say, it doesn't hurt as long as I don't play with my kids. Well, heck, you can't not play with your kids. So that's when we should try, one, the non-surgical stuff. And if that fails, last resort, do the surgery stuff. In terms of what is the surgery stuff, well, it really, really varies based on what your symptoms are and what the pathology is. Also, it could be some of surgeon training, the technology that surgeon's familiar with, but I'm going to break it down into a couple different types of surgeries for the surgical treatment options for lumbar spinal stenosis. So the number one goal and the thing that any surgery has to do is take the pressure off the nerves. Again, if you're looking down the tunnel, you need to take the pressure off of here. Now, there's kind of two different types of surgeries. There's an indirect decompression. And that's where if this is a spine model, you can put a cage in the front, and if these tunnels, as you can see right here, if they were closed down, they were bone on bone collapsed, a cage would open up these tunnels and make that much wider. So it allows the tunnels and the nerves to open up much wider. That's a much better treatment option for when the nerves are compressed. These cages vary. Back in the day, it used to be cadaver bone. Now some surgeons use a medical plastic called PEEK. That one's okay. Many surgeons now use a titanium, 3D titanium, but a titanium alloy that allows the bone to grow into it, opens it up. Advantages and disadvantages in terms of what goes inside that disc space. But not every surgery necessarily needs a fusion. Those are only fusion surgeries where you need a cage inside the disc space. Again, the whole goal in terms of getting lumbar spinal stenosis better is taking the pressure off the nerves. So putting in a cage here is an indirect decompression where it indirectly opens up those nerves. To directly open up those nerves, a traditional approach, which is the much more common one also, is when the spine surgeon makes an incision on the back, and it varies in size based on one, training, two, the technology, and three, what needs to be done. And they go in and they shave off some of these bones here, something called a laminectomy, where you remove this part of the bone right here, the lamina. So this goes here, you're shaving off this part, and you clean out all these nerves here. Now in this spine model, it took off part of the joint. This is the joint. A spine surgeon wouldn't actually take off the joint unless they're doing a fusion. If the spine surgeon has to take off part of the joint to address your pathology, then you need a fusion. It'd be similar to where if they had to take out your knee joint, you got to put something else there. And that's usually a fusion in terms of spine surgery. So in terms of the taking the pressure off the nerves. It's something called a decompression surgery or a laminectomy, where they shave off the bone here. The people that need a fusion, the rods and screws to treat lumbar spinal stenosis, it varies based on patient, it varies based on training, but in general, it's when there's instability, one bone's moving forward on the other, if it's a bone-on-bone pathology, or if there's severe arthritis where you have to remove part of the joint in order to get that nerve freed up. Those would be the indications for the rods and screws and a fusion procedure. Now, another form of treating lumbar spinal stenosis is a disc replacement. That's when a surgeon teamed up with a vascular surgeon would make an incision under the belly button, move your veins, your aorta, your vena cava all to the side, remove that disc space and put in a disc replacement there. And that's a way that treats the front part of the spine, going through the belly, not going through the back. Huge advantages, huge disadvantages with all these treatments. These are just the different options in terms of treating spinal stenosis surgically. Now, in terms of minimally invasive versus non-minimally invasive, the thing I always tell patients is, in a way, it's somewhat of a marketing term. There's not a formal definition of what makes a surgery minimally invasive. So ask your surgeon, what do they mean by minimally invasive? Is it that their incision's this big, but the guy across the street or girl is that big? Well, that's not a true definition. Minimally invasive surgery should be small incisions, maybe the size of your thumbnail, dropping tubes, using a microscope, using robotic technology, using 3D navigation, things that allow us to see under the skin and under the muscle so that it lessens the pain associated with spine surgery, improves recovery, enhances recovery, and allows the patient to get their life back much faster than if you did the big open traditional incision surgeries. So that's what minimally invasive surgery means to me and most people that are proponents of minimally invasive surgery. It's small incisions, doing the least amount of surgery possible for the biggest outcome.